Good evening, everyone. Welcome to our Understanding Dementia community presentation. My name is Erica Zarzin, and I'm the Public Awareness Coordinator for the Alzheimer's Society of Saskatchewan. It is my pleasure to welcome you tonight to our Understanding Dementia presentation featuring our guest presenter, Dr. Jillian Gill. Before we get started, I just want to let you know that the presentation is being recorded, but only the presenters will be shown on video, not the participants' names or videos. During the presentation, we ask that you please type your questions in the Q&A function at the bottom of your screen, and we will have a question period at the end of your presentation. We ask that you keep your questions relevant to the presentation, as we will not be addressing any personal concerns tonight during the presentation. If you would like to address your personal concerns or connection to dementia, or you just need individualized support, please contact our Dementia Helpline at 1-877-949-4141 or helpline@alzheimer.sk.ca. This is available Monday to Friday, 8:30 a.m. to 4:30 p.m. So thank you for your understanding and participation today. Again, I want to thank you all for joining us here today. Because the Alzheimer's Society of Saskatchewan is a provincial-wide organization, I would like to offer a land acknowledgement from a provincial perspective. The people of the Alzheimer's Society of Saskatchewan are privileged to live and work across the traditionally sacred land we now know as Saskatchewan. We recognize the enduring presence of the Cree, Dakota, Dene, Nakota, Lakota, Saulteaux, and Métis people, who are the original stewards of the rolling hills, rushing rivers, and living sky we all share today. As an organization, we acknowledge the harms of the past and how Indigenous people are still impacted by the process of colonialism. Through our partnerships, education, and collective action, we commit to honoring our relationship to the land, our treaties, and each other as we journey towards reconciliation. I would now like to introduce and welcome Dr. Jillian Gill. Originally from Southwestern Ontario, Dr. Jillian Gill earned her Bachelor of Commerce with an honors Business Administration and Computer Science co-op with distinction at the University of Windsor before pursuing medicine at the University of Saskatchewan. During her family medicine residency, she was recognized with the Family Medicine Award for Scholarly Achievement and the Jason Hoyson Award for her dedication to comprehensive patient-centered care. She practiced as a community family physician in Saskatoon and briefly in Vancouver for a decade before focusing her career on geriatric medicine. Today, Dr. Gill is part of the Geriatric Evaluation Management Program, also known as GEM, at Saskatoon City Hospital, where she works with GEM Day Hospital and multidisciplinary clinic teams to provide diagnosis, treatment, and compassionate support for older adults and their families, particularly those navigating dementia. So thank you and welcome, Dr. Gill.
Thank you, Erica, and thank you everyone for joining me today to learn more about dementia on Alzheimer Awareness Month. It'll be just a moment as I get control of the slideshow. So as a result of attending today, you'll learn a little bit more about the types of dementia, risk factors, possible signs of dementia, and the importance of gaining an early diagnosis. You'll also learn about programs and services offered by the Alzheimer's Society. So oftentimes people think that the words dementia and Alzheimer's disease are interchangeable, but they're not. The term dementia is a medical term used to describe individuals who are experiencing memory and thinking changes that have started to affect their activities of daily living and their ability to function in their everyday lives. It's an umbrella term to describe many different forms of dementia. This is not an exhaustive list, but some of the most common types: Alzheimer's disease, vascular dementia, Lewy body dementia, Parkinson's disease with dementia, frontotemporal dementia, and mixed dementia. I think I'll probably be a very slow slide changer, so I apologize for that. This slide shows us a little bit about how dementia affects the brain. On the left-hand side, you can see a normal brain cross-section where you have very plump brain tissue. On the right-hand side, we have an example of an Alzheimer's patient and their brain. And you can see that we've lost some tissue in the temporal lobe, and this affects memory and language. And this is one of the reasons that we have specific symptoms with specific diseases. On this map, we can see that different locations of the brain are connected to different functions. So, for instance, we said the temporal lobe affects memory and language, and we lose tissue in Alzheimer's disease in this area. If another area of the brain is affected, like the frontal lobe, we may have changes in emotion and behavior and personality. So what causes dementia? It's important to know that dementia is not a normal part of aging. As we age, we can have some minor changes to our memory and processing speed, but these do not impair our activities of daily living. Dementia is caused by changes in the brain, and each disease has a specific change to the brain. For instance, Alzheimer's disease, we now know through research, is caused by an accumulation of different proteins like beta amyloid and tau in the brain tissue. When we're discussing the causes of dementia, it's important to get an early diagnosis because we want to rule out acute reversible causes of dementia. This is not an exhaustive list, but it's important to look at medications you're taking, signs of infection, depression, dehydration, stress, tumors, and vitamin B12 deficiency. So by speaking to your physician early when you have a sign of dementia, we can rule these out quickly. We're going to talk a lot more today about the chronic irreversible causes of dementia, the neurodegenerative dementias. This again is not an exhaustive list, but some of the most common. As you can see, we'll be talking about Alzheimer's disease today, but there are other common forms of dementia like vascular dementia, frontotemporal dementia, dementia with Lewy bodies, Parkinson's disease with dementia, alcohol-related dementias, and acquired brain injury. We'll talk a bit more about Alzheimer's dementia. It is more than just memory loss. So when we're looking for signs of dementia, we look for more than memory. It can be changes in language, but it definitely affects a person's day-to-day function. It is progressive, degenerative, and irreversible. We do not have a cure at present time for Alzheimer's disease. When we're thinking about signs and symptoms of Alzheimer's dementia, we often think of it coming on very gradually and slowly over many years. This might look like very mild changes in memory at first and progress over time. When we speak of the stages of dementia, we break it up into early, middle, late, and final stage. In the early stage, individuals will likely need a little bit more help with what we call instrumental activities of daily living. These are things like managing their finances, remembering to take medications, and they may have some forgetfulness, changes in mood, withdraw from some social activities or other activities they like to do, and might have some coordination problems. You'll notice when they're walking, they might trip more often or have a harder time getting around other things. In the middle stage or moderate dementia, this is where we start to notice that the individual will have more trouble with our basic activities of daily living. These are things like dressing, walking without assistance, and attending to personal hygiene. So a person in moderate stage dementia might need cues to put on their clothes in the right direction, and they might need reminders to do personal hygiene. They may have more difficulty recognizing familiar things, have personality changes, are not able to concentrate, and as I said, will need assistance with those daily tasks. In late stage dementia, we notice that they will need help with those activities of daily living. So they may need you to help feed them, or an individual may need you to take them to the toilet rather than just cue them to do these things. And there's a loss of ability to remember or process information. They may completely withdraw from social activity and use more nonverbal communication. At end of life, we really want to focus on a person's spiritual, emotional, and physical well-being and focus on comfort care. There are many established risk factors of Alzheimer's dementia. You'll notice throughout our talk today, I'll talk a lot about cardiovascular risks, and these will be a part of Alzheimer's dementia risk factors as well. So older age is a risk factor, head injury, particularly with loss of consciousness, elevated blood pressure, cholesterol, smoking, obesity, diabetes, stroke, and cardiovascular disease like history of heart attack can be a risk factor. Having a higher education level is protective for developing Alzheimer's disease. Depression is a risk factor. And genetics are a risk factor. So we know that genetics increase your risk of Alzheimer's disease. For instance, family history of having a family history of a first-degree relative with Alzheimer's disease does increase your risk of developing it by 10 to 30%. But none of these risk factors mean that you will develop Alzheimer's disease in the future. Other genetic things we've discovered through research include the gene ApoE4. This gene, if you have one copy, increases your risk factor, and then 2 copies increases that risk even more. Down syndrome is interesting because it is affected by the 21st chromosome. There are 3 copies of that 21st chromosome, and the 21st chromosome has a specific gene associated with early onset Alzheimer's disease, the APP gene. So we think that in Down syndrome, we create more beta amyloid as a result of this. The next type of dementia we'll speak about is vascular dementia. This is when the vessels, either large or small, can be occluded and are not bringing as much oxygen and nutrients to the brain tissue. And as a result, those neurons can die off. As compared to Alzheimer's disease, vascular dementia tends to be sudden onset, and then as it progresses, there may be some stability and then another sudden onset change. Vascular dementia has risk factors very similar to those we associate with cardiovascular disease. So that includes being over the age of 65, having diabetes, high blood pressure, high cholesterol, smoking, and heart disease. Dementia with Lewy bodies is another common form of dementia. We use the term Lewy body dementia to include both dementia with Lewy bodies and Parkinson's disease with dementia. In both these processes, there are abnormal protein substances called Lewy bodies, and they form within the brain cells. Lewy body dementia can have specific symptoms we look out for. Dementia with Lewy bodies, we tend to notice changes in a person's alertness and fluctuations in their cognition. So this might look like someone who is having a conversation and then will zone out for a long period of time. Dementia with Lewy bodies also tends to have symptoms like visual hallucinations. They may have changes in their sleep where they're more active in their sleep. And then it can be associated with also having symptoms we associate with Parkinson's disease, like slow movement, rigidity, and tremor. Dementia with Lewy bodies can be more rapid in progression than we would see with Alzheimer's disease. In frontotemporal dementia, both the frontal lobe and the temporal lobe can be affected. And if we remember that brain map, we can see the frontal lobe controls things like emotion, personality, planning, and judgment. And the temporal lobe affects language. Frontotemporal dementia tends to occur at a younger age, and the first symptoms we see may be behavior changes rather than memory loss. So this might look like not understanding specific words or language. They may appear more apathetic, not as motivated to do things as they once were. And this might be a change in personality. They may have decreased social judgment, so may swear where you wouldn't expect them to. In mixed dementia, which is quite common, we see characteristics of more than one type of dementia at the same time. The most common form of mixed dementia is Alzheimer's disease and vascular dementia. Where we might notice this is if an individual had a very slow progression of memory changes over time and then had a sudden stair-like progression in their cognitive function. Mild cognitive impairment is not a type of dementia, but what it is a decline in cognition, but the individual retains the ability to complete routine functions and activities. They tend to be able to be independent. A person with mild cognitive impairment is at increased risk for developing Alzheimer's disease or another type of dementia, but not all individuals have progress to their symptoms. We would like to identify people in the stage of mild cognitive impairment so that we can make changes in their lifestyle to reduce their risk of developing a dementia. And there is one treatment available in Canada that is very new, and that treats mild cognitive impairment. We'll talk a little bit more about that later. One very important question that I'm asked by many families of individuals with dementia is what they can do to reduce their risk of developing dementia in themselves and other family members. Risk factors of dementia are both modifiable and non-modifiable. The non-modifiable ones include older age, your family history, and unfortunately for me and the ladies in the audience, being a woman increases your risk of dementia. However, on the right side, we have 14 identifiable risk factors that we can modify. We can modify them throughout our life stages. And if we were to eliminate all of these risk factors, this would reduce the prevalence of dementia in the world by up to 40%. You'll notice throughout the presentation, when we were discussing risk factors, I talked about cardiovascular risk factors, and it's true, what's good for the heart is good for the brain. So if you're wondering what you can do to reduce your risk of developing dementia, we'll go through some. Attaining the highest level of education possible is protective for developing dementia. Hearing loss is associated with developing dementia, so protecting your hearing now by wearing hearing protection at work and during recreational activities like concerts and drag races is very important. If you identify you're having hearing trouble, I recommend getting your hearing treated with hearing aids. We want to prevent head injury. We can do this by doing simple things like wearing our seatbelts, wearing helmets at work if it's needed, and in our recreational activities like biking, my favorite thing to do. We can eat a well-balanced, healthy diet. There have been two diets in particular that have been researched to reduce the risk of developing dementia. This includes the Mediterranean diet as well as the MIND diet, which is a combination of the Mediterranean diet as well as dietary approaches to stop hypertension. To reduce risk, I recommend limiting alcohol use. The current Canadian guidelines recommend less than 2 drinks per week. We also recommend avoiding smoking. We can reduce our risk by managing depression. If you're feeling symptoms of depression, it's important to speak with your healthcare practitioner about how you may treat this. Very important late in life is that we continue our social activity, continue seeing your family and friends frequently, go to coffee, make that phone call. And last, but definitely not least, and my favorite modifiable risk is exercise. I recommend that you incorporate 150 minutes of moderately vigorous exercise into your week. There have been many advertisements touting the benefits of different supplements to prevent dementia. And unfortunately, there haven't been any dietary supplements or herbal remedies that have proven benefit to prevent dementia. Some in particular are selegiline, estrogen replacement, non-steroidal anti-inflammatory medications. So that's medications like aspirin or naproxen, antioxidants like vitamin E, C, selenium, beta carotene, and supplements like vitamin B6, B12, folate, omega-3 fatty acid, and ginkgo biloba. As we've talked about throughout the presentation, memory loss isn't the only sign of dementia. There are 10 evidence-based signs that are associated with dementia, and we would like to talk more about them so that we can understand these signs and improve access to a timely diagnosis. We've organized these signs into 3 categories: the ABCs of dementia: abilities, behavior, and communication, and we'll dive into each of them. Importantly, the signs of dementia have to be a change from normal function for a person. So if Aunt Clementine has collected every star phoenix since she was 20 years old and it has sat in her apartment her whole life, that's probably not going to change. If you've never been good at remembering names, still continuing to not be good at remembering names is not a sign of dementia. So keep that in mind, that these signs need to be a change. In the abilities category, we think about memory changes that affect day-to-day abilities. This might mean repeatedly asking for the same information or forgetting recently learned information. It's really important to keep in mind that this is a result of changes in the brain function and structure. The individual doesn't mean to be repeating often, and it can be frustrating, but they really don't intend to be repeating. An individual could forget how to use an object or not recognize it, like picking up a can opener and not knowing how to use it. An individual might have difficulty doing familiar tasks and struggle with the order of tasks. They may forget sequences that used to be second nature. Like for instance, if you're making a pot of coffee, they may consistently forget to put the filter in. They may forget components of a familiar task. And this might look like forgetting how to make a recipe that they've made thousands of times by heart. An individual might have disorientation in time and place. They may get lost in a familiar place, forget the route home, or have difficulties with concepts of time, such as change of season. This is an important sign to recognize because this can be dangerous. We want to think about ways that we can protect our loved ones by having apps and different things that we can use to follow our loved ones. So this might look like having their phone on and GPS on the phone, but there are many different ways that we can think about doing that. An individual might begin to misplace things. They may lose items or put them in an odd or inappropriate place, like keys into their freezer. They may be unable to retrace their steps to find a lost item, and that can be really frustrating. This may also lead to an individual accusing others of stealing or moving an object around. Onto the behavior warning signs, we think about impaired judgment. This might be changes in how they're making decisions. For instance, they might not recognize a medical problem such as an infection as dangerous and ignore it. There might be poor judgment with money, and that might lead them to be scammed by someone. There might be changes in mood, personality, and behavior. We all have ups and downs, and sometimes we may seem more grumpy than usual. But where we see this is when there's a change in mood quickly and for unapparent reasons. There may be crying where you don't expect that to have happened, or uncharacteristic confusion, suspicion, or paranoia. We may see an individual using impolite or harsh language, which is completely out of character. Another behavior we look for is loss of initiation. An individual may not be attending the hobbies or activities they once did. They may need cueing to go and do something where they used to be a go-getter and would have many tasks that they want to fulfill through the day and now spend the day in the chair. They may need you to remind them to do things that they once just did by themselves. There may be changes in sight or motion. This is a result of the changes of the brain in specific areas. They may have problems seeing things correctly and have trouble with depth perception. You may notice changes in their coordination, like bumping into things. When there are changes in vision, it is really important that you seek out the help of an eye professional to rule out eye disease as a cause. In the communication section, we talk about changes in language. This could be loss of vocabulary, using different words that aren't appropriate, or making up completely new words. They may repeat words over and over again, or have trouble organizing their thoughts into sentences. They may show difficulty understanding text or speech. An individual who is developing dementia might have problems with abstract thinking. They may not understand numbers, time, money, things that are used to represent other things. And we often look at how an individual draws a clock to see if they're having some changes with their abstract thinking. I want to point out that each of these signs do not mean that you have a diagnosis of dementia, and all of us have mild changes in our memory and thinking from time to time. There are many benefits of having an early diagnosis, and this includes understanding the signs and symptoms like we're doing today, rule out those treatable causes so we can reverse them, so you can access treatments early to get resources and supports, to plan and prepare for the future, and then to consider non-pharmacological approaches to maximize quality of life. There are many services out there so that you can enjoy things like exercise, and we'll talk a little bit more about them with Erica. When you're suspicious about dementia, it's important that you understand, as you're trying to get a diagnosis, that there is no single test to diagnose. It can be a lengthy process that requires many follow-ups, and it might involve a medical history, physical exam, cognitive testing, laboratory tests, medical imaging, and neuropsychological evaluations. When you see your doctor, please share any changes you've noticed, things that you're finding difficult to do, the time frame that you've noticed this. For instance, if Last Easter, you noticed you couldn't put together the meal that you thought you would do in the past. That's something to anchor onto. Please share your medications, both prescription and over the counter, psychiatric history, family history. We often ask that you bring a family member or caregiver, and we do trust that you know your history, but it's important as we're investigating dementia that we recognize that individuals with dementia may not understand all of the changes that are happening to them, and we would like to hear from a caregiver if there's any other changes. One incredible tool that we can use to organize all of these thoughts is the Getting a Diagnosis Toolkit, and it's available from abcdementia.ca. When we speak about treatment for dementia, there's both non-pharmacological treatments and medications. This includes education, just as you're doing tonight, support for the person with dementia, as well as their family and caregivers. It includes developing a healthy lifestyle, including exercise, social activity, and cognitive challenges. And then, in some cases, we can use medications. All the medications approved in Canada right now have the goal of slowing down decline in thinking and with an idea that we want to help maintain independence. The following medications are currently available to treat symptoms in Canada. The first three, Aricept, Exelon, and Remenil, are in the cholinesterase inhibitor category. We use these medications in many forms of dementia, from mild to severe dementia. Abixa or memantine is an NMDA receptor antagonist, and we use this medication more often in moderate to severe Alzheimer's disease. This year, we had some exciting news. Health Canada approved the first disease-modifying therapy, lecanemab, this year. It's currently not available in Saskatchewan, and the first individual in Canada was treated with this in the last month. This therapy targets those amyloid plaques that I was discussing in Alzheimer's disease. There are very specific eligibility and some serious potential adverse effects, including hemorrhage and edema of the brain. Our goal of this medication is to slow the progression of cognitive and functional decline. It involves having an IV infusion over 1 hour every 2 weeks for 18 months, and then a possible maintenance dose monthly. Current approved medications, including lecanemab, do not cure Alzheimer's disease, but we like to start them early if possible so that we can slow progression of the illness. It's an exciting time to work in dementia care. There's lots of research going on about treatment and prevention of dementia. Some things that are on the horizon include recently we found that the herpes zoster or shingles vaccination may reduce risk of dementia. There's also a lot of research about the relationship between vessel health and brain health. There's research on the use of intranasal insulin to possibly treat mild cognitive impairment. And there's many drugs looking at targeting beta amyloid protein plaques in the brain. Currently, the lecanemab uses the immune system to reduce plaques, and there are drugs that are being tested now that would block production of plaques. Going back one slide, I wanted to mention that we use lecanemab for possibly mild cognitive impairment in very specific individuals, as well as mild Alzheimer's disease. And this is really exciting because this is the first time we've had a pharmacological treatment for mild cognitive impairment. So now that a diagnosis of dementia has been established, what should you do? Well, I recommend you contact the Alzheimer's Society of Saskatchewan so that you could benefit from their many resources and services. We also want to think about future planning, establishing legal documentation like a power of attorney so that your values and wishes are implemented by a person you trust. I also recommend you complete a healthcare directive to establish a healthcare proxy, someone who will make decisions about your medical health if you're not able to communicate them. In dementia, at some point in time, an individual will need to stop driving. It's important to have these conversations early to establish alternate transportation and also allow the individual to grieve that loss of independence. When we've established a diagnosis, we can talk more about medication management and whether or not it's appropriate for you. We also want to establish early if there are any changes in the living environment that need to be made in order to live safely and have the best quality of life. Well, thank you everyone for listening to me tonight. I'm going to pass the baton back over to Erica.
Thank you so much, Dr. Gill. I know I learned a lot tonight, and I really hope everyone else did as well. We will get to questions in a few minutes. We really hope that everyone feels a little bit more confident in your knowledge about dementia after hearing this presentation. And we welcome any questions that you may want a little bit more explanation on, or to clarify anything that we talked about tonight. If you would like, there's a Q&A box at the bottom of your screen. So you have some time to type in your questions that you may have jotted down or ones that you've been saving while I give you some information about the Alzheimer's Society of Saskatchewan. So our vision here at the Alzheimer's Society is a world without Alzheimer's disease and other dementias. And the mission is to empower people to live well with dementia through the delivery of programs, services, advocacy, awareness, and research. A couple things to note about the Alzheimer's Society is you do not need a formal diagnosis to be connected to us, and we support those affected by Alzheimer's disease and other dementias, and we do have resources and knowledge about many types of dementias. Sorry, my screen. So the Alzheimer's Society of Saskatchewan offers help for today through our programs and services for people living with dementia, and hope for tomorrow by funding research to find a cure and to improve care. We have trained programs and services staff that provide information, support, and education throughout the province. And our provincial office is located in Regina, with additional resource centers in Saskatoon and various locations across rural Saskatchewan. Actually, in the 2024-25 fiscal year, the Alzheimer's Society of Saskatchewan served over 3,300 clients from 360 different communities across Saskatchewan. And it is currently estimated that 20,000 people in Saskatchewan are living with dementia. And the recently released Alzheimer's Society of Canada's landmark study is projecting that number to grow by 142% in the next 30 years. So if you have questions about dementia or need someone to talk to outside of this presentation, we do welcome you to call our toll-free dementia helpline at 1-877-949-4141. So what can you expect from the Alzheimer's Society of Saskatchewan? You can expect individual information and support through our First Link program. This connects persons with dementia and their families to information, support services, and education as early as possible and throughout the progression of the disease. Our First Link coordinators provide individualized support and each client is offered follow-up by Alzheimer's Society staff throughout their journey. We also have opportunities for connections. So we have our Minds in Motion program, which is a 2-hour weekly program that combines physical activity and social activity for those with early stage dementia and a friend, family member, or care partner. We also offer connections to other organizations. We can provide information on available services provided by the Saskatchewan Health Authority, other government agencies, and lists of private or community-based organizations that help support people's dementia journey. And we also have support groups, Alzheimer's Society of Saskatchewan support groups, such as early stages of dementia, for example, offer a chance to exchange information with others living with and affected by dementia, access the most current information, and learn and share practical tips for coping with change, decreasing feelings of loneliness and isolation, expressing feelings and being reassured that these feelings are normal, and to find a sense of hope. We also provide learning opportunities because we do believe that knowledge changes everything. Like tonight, we offer our annual Understanding Dementia presentation. We also offer learning opportunities throughout the year, such as our learning series, which are courses to help people with dementia, their families, and friends to live well as possible with the disease. These courses offered build upon each other, covering the continuum of the disease. We also offer standalone evenings of education, which are topics presented by content experts. We have our Dementia-Friendly Communities presentation coming up next month, as well as our Healthier Brains presentation in March. So we always like to have events to help educate people and give you opportunities to learn more about dementia, but we hope you will join us with those as well. Perfect. And lastly, before we get to the questions, we know, sorry, again, we believe community changes everything as well. And it really does. Have you ever maybe thought about hosting your own event or activity in support of the Alzheimer's Society of Saskatchewan? Then do Anything for Alzheimer's. Anything for Alzheimer's is a way for creative, dedicated individuals and businesses to get involved and make a difference in their community. You can plan your own fundraising event or turn an existing event into a challenge, our challenge into a fundraiser. Whatever your interests or talent, there's an event out there for you and your community. So again, you can contact our offices if you'd like some more information about that. And lastly, did you know that 3 out of 4 every dollars the Alzheimer's Society of Saskatchewan receives actually come from donations? These donations help us to inspire hope and to provide early diagnosis, to reach greater awareness throughout our communities, funding new medications and treatments, to provide strategies for coping, as well as to provide caregivers the confidence in their abilities, and to continue to serve Saskatchewan communities with support and resources that are reflected to one's needs. Then this last slide is, again, our dementia helpline number, as well as an email that you can email to follow up with us from this presentation. So I hope everyone typed their questions in the chat so we can get them to Dr. Gill. My bar had disappeared. Okay, so the first question that we received is, Dr. Gill, is it possible to have Alzheimer's with Lewy body? So maybe we want to explain the uniqueness of Lewy body dementia.
And can you hear me now?
Yes.
Excellent. So when we were discussing mixed dementia, I gave the example of Alzheimer's disease as well as vascular dementia, and that is very common. But it is also common to have both Alzheimer's disease and Lewy body dementia, particularly after the age of 85. We tend to have more than one type of dementia affecting cognition in those individuals. So it is very possible to have that. What that may look like is those slow, progressive changes in memory over time, and then noticing that there's been a big change, and that might look like sudden visual hallucinations, more falls, changes in movement. So it's very, very possible to have multiple types of dementia at the same time. And we do think mixed dementia is more prevalent than we actually realize at this time.
Thank you very much. Okay. Dr. Gill, what are some of the signs that can confirm a change that a living environment is necessary?
So I think this is a very, very important question. Early on in dementia, we think about safety. So the first things that may be signs are a change in a person's and safety in their own home. So if you're noticing that there are falls occurring in the house, or an individual is not turning off the burners when they're cooking and there's burnt food, those can be the first signs that a change in the living environment need to happen. If a person is afraid of falling and worried about getting into the shower because they're afraid of slipping and falling, that's another sign that you may need a change within your living environment. Later in the progression of the disease, as an individual is needing more assistance with activities of daily living, for instance, needing someone to help them bathe or have a shower, needing someone to help cook, um, we have to make the decision at that point. Do services come into an individual or as a caregiver providing that service, or does the individual need to move to a different environment where that's provided? I did see later on, you had asked about what do we do if a parent doesn't want to move in those scenarios? And that is a really, really difficult decision. Oftentimes we talk about the pros and cons of moving to a new environment, but it is very difficult. There may come a time where the person with dementia isn't able to make educated or fully informed decisions about their living environment. And at that time, we may decide that their loved one or the person that they chose as their power of attorney um, make the decision for them to move, even though at this current time where they're not able to make that decision, they're going against it.
Thank you for that. We've gotten a couple questions about the GEM program. So would you be willing to explain what the GEM program offers?
I would
And
love to.
yes, kind of the process and time frame too.
Yes. So, in order to access our GEM program, your family physician or nurse practitioner or a specialist physician in the community sends a referral to our program with the current concerns that the individual is having. From there, we have a wonderful team made up of physicians, nurses, physiotherapists, social workers, occupational therapists that meet and look through the referral and make a decision about what service that we can provide. We typically have three service streams currently. The first is that an individual see a geriatrician who is an internal medicine trained individual who does a comprehensive geriatric assessment. Those often are very complex patients that would be in that stream. The next stream is multidisciplinary clinic. In that case, an individual would see in one day over consultation a social worker, physiotherapist, occupational therapist, and perhaps a psychiatrist, and then a physician all in one day. And we do an assessment and give recommendations that go both to your family doctor as well as written information to the patient and family, so that could be implemented. The third stream is our day hospital stream. In that service, an individual comes 2 days a week to our program from 9 a.m. until 11:30 p.m. and they can benefit from all of the different services that we have. So they would see recreational therapy, physiotherapy, occupational therapy, have socialization, so lots of opportunity to chat with other patients in the program, and then they would be followed by a physician like myself throughout that time. Oftentimes, the day hospital lasts 6 weeks of attending 2 days per week. At the end of that service, we have a family conference with the patient and their caregivers or family, so we can explain their successes through the time. I hope that answers the question.
I hope so too. Please let us know in the chat if you have any follow-up questions about the GEM program. Thank you, Dr. Gill. We have some questions based on medication or a little bit more about mixed dementia. Do you know which direction you'd rather go right now?
So, well, I can start at the top of my question answer. I have the
Perfect.
mixed dementia question. So the question is, how do you know if someone has mixed dementia? And if they do, is treatment any different? The way we determine if someone has mixed dementia currently is by their clinical progress. We think about the symptoms that are grouped into each disease and then the timeframes that they occur to make a determination if they have mixed dementia. The treatment may differ depending on what combination we have. For instance, an example would be in Lewy body dementia, we know that individuals who have that are very, very sensitive to what we call antipsychotic drugs. They can be very dangerous for those people. So if someone with Lewy body dementia and Alzheimer's disease is experiencing symptoms of hallucinations or having delusions or are unsafe to themselves, we have to be very careful with that combination before we would start an antipsychotic drug. That was a really intense answer to a question. I apologize for that. But yes, the treatment can differ.
Okay, thank you. Does the new drug getting released reverse plaque buildup or just slow the symptoms?
So that is a very good question. It does reverse plaque buildup. So on scans, it's followed by MRI and PET scans that look at amyloid plaques, and it does remove those amyloid plaques. Unfortunately, at this time, it doesn't cure the disease. It just slows the disease progression. So what you said is right. It reverses the plaque, but it does just slow the symptoms. So we're not curing the disease.
Very interesting. When you talk, oh, I was going to read one and it disappeared. Sorry about that. Can you talk a little bit about why dementia is going to increase so much in the next 30 years?
Well, we do know one of our risk factors of dementia is age. As the older we are, the more likely we are to develop dementia. We do know that our population is aging, so we're going to have more individuals who are going to be over the age of 65. In addition to that, we are keeping people alive longer by treating their comorbid diseases. So if we're treating cardiovascular disease, like treating heart attacks and high blood pressure and high cholesterol, we are making them live longer and as we age. we have a greater chance of dementia. So it's a combination of people living longer, and we are having many more people who are over the age of 65.
Wonderful. So on that topic, someone wants clarification on if there are 3 intravenous medications that slow down the progression of Alzheimer's, or
So
was there
yeah.
just the one?
So I'm just looking for the question. So there has only been one medication approved by Health Canada for reversing the plaques. In the US, donanemab is also used. I think there's research on many, many other medications, but in the US, they have 2. In Canada, we have 1 at current time.
And one of the American ones is the same as the Canadian one that we have, or are they all different?
Yes, sorry, I should have clarified that. One is lecanemab, one is donanemab. They work very similarly and have similar side effects. They're quite similar at this time. We may have access to both of them in the future, but at current time, only lecanemab is approved.
Thank you. So there's a question if you could speak more about the relation between hearing loss and dementia.
I don't know that we fully know the complete relationship, but if we think about the stimulation that hearing gives our brain, it activates neurons, and we want our neurons to be as active as possible. So it's almost like exercise for our brain. So if you cannot hear, you're not getting that cognitive stimulation from hearing, and also people often withdraw from social communication, so they don't tend to be as involved in conversations, which also stimulates our brains. So that's the proposed reason why there's an association between hearing loss and dementia.
Lots of more questions about the GEM program. So let's switch over to that.
Okay.
Are there GEM teams in rural Saskatchewan outside of Regina and Saskatoon?
Well, so our program is very specific to Saskatoon. There are rural memory programs. I am definitely not the expert on them, but there are availability of other programs in the community that are more rural. Erica might actually know a little bit more about that than I do. Radar is one that is on my mind, and then there are memory clinics in North Battleford as well, I believe, but I might have to pass that back to Erica.
Yeah, if you wanted to call our dementia helpline, we can connect you with what might be closest to your community as well. I can post that number again in the chat. But thank you. So
And just to clarify, because you're from a rural area, does not mean you can't access our program. It just means that unfortunately you'll probably have to come to Saskatoon to see us, but we take referrals from all over the province, and we're very, very happy to help anyone in the province.
can you answer maybe how long does it take to generally see a geriatrician in Saskatoon?
So I don't know that I can speak specifically to the geriatricians, but to access our program, during that triage process, we do identify if an individual needs to be seen urgently, and we usually see those people within about a month. If it is deemed not urgent or not related to safety, oftentimes the wait list for the various services is between 3 and 6 months. And that varies almost weekly, but we do try to see people in a very timely manner.
Well, and then there's a lot of difference in diagnosis too. So when someone's going through a dementia diagnosis, that's not the same for everyone. So the time frame on that can look different as well, right?
Yes, and we do try to keep that in mind. So if there are safety concerns, we do address those right away.
And say if someone's already seen some of the health professionals that are at the GEM program, would they be able to take their reports to the GEM program staff, or do you like to do those yourself? Like if they've already had seen multiple doctors.
Oh, we love to have as much information as we possibly can. I would welcome any documentation you have. We do have a very wonderful team of nurses that do research and outreach early on to try to find as much information as possible, but I very much welcome any additional consultations that an individual's had beforehand.
Thank you. How long does it take dementia to progress from onset to advanced stages?
That is a really, really important question. Every single individual with dementia has a different progression through their disease. It depends on many different factors. So no two people are going to be the same, even within diseases. In Alzheimer's disease, we do tend to see a slower progression. Some people may have a progression over 8 years. Others might have a progression over 20 years. And there's a lot that goes into that. There are some forms of dementia that progress faster, including Lewy body dementia, where we tend to see progression over 3 to 5 years or less. But it's very specific to the individual. It's not a clear-cut answer for certain, and I'm sorry for that.
No, thank you for clarifying. So kind of speaking on that, would a family doctor prescribe medication for someone with mild dementia or early stage without a diagnosis yet?
So I do think it's very important that we establish a diagnosis of dementia. Your family physician can make that diagnosis if they feel confident in that. And I would love to see all the family physicians and nurse practitioners in the province feeling that comfort, because we talked about that timely access to a diagnosis and all the benefits that come from it. Many physicians do feel comfortable prescribing the medications we talked about that slow the progression of Alzheimer's disease. It would depend on your own practitioner's comfort. And then if they don't feel comfortable, that's where they would make a referral to the GEM program or neurology so that they can have a definitive diagnosis.
Thank you. And it talked a little bit about the risk factors and what's good for the heart is good for the brain. So would you be able to talk a little bit more about the brain-heart connection for dementia?
Well, that's something that we don't know everything about. And that's why when we talked about research, there's a lot of information going into knowing more about that connection. Vascular dementia and Alzheimer's disease both are affected by how healthy your vessels are. So if we're keeping good healthy vessels by treating high blood pressure or not having high blood pressure at all, treating cholesterol, treating blood sugar, we're keeping those vessels healthy so that the appropriate oxygen and nutrients can get to the brain cells so those neurons remain healthy. If we do have heart disease, things like heart attack, we're taking away some of that perfusion to the brain, and that can affect cognitive function. So healthy vessels anywhere mean a healthy brain.
Could you explain a little bit about how vascular dementia would be diagnosed? Is it different or the same?
So going back to, I'm just maybe not. I don't need to go back to this slide.
Oh,
No, I really don't. I thought it might be easier to see. But for vascular dementia, we take the process very similar to other forms of dementia. So we take a very thorough history, and that history may include things like heart attack, stroke, high blood pressure, high cholesterol, diabetes, smoking history, or alcohol history. So that's a sort of a flag that might be vascular dementia might be um, something we're thinking about. We then do a physical exam to rule out any signs of stroke. So when I'm with a patient, I'll be checking their strength and their sensation. And if it's not congruent on both sides, we think about, is there a large change in a blood vessel? After physical exam, we can do lab work. And that may be simple tests that your family doctor is already doing, like measuring your cholesterol, measuring your blood sugar, because that can be an indication that vessels might be impaired. Not everyone needs neuroimaging, but we often do that. And on that neuroimaging, we look for any areas where we suspect a stroke. So that would be a large blood vessel that's been occluded. And as a result, the neurons in the brain tissue there have died off. And we can see that on imaging. But what we also look for are small areas that again have died off over time because of the teeny tiny vessels that have been affected by high blood pressure or cholesterol. So those things together can put together a diagnosis of vascular dementia. The process is similar, but we look for different things.
thank you. We are almost getting to the end of our questions. So if anyone has any last minute questions that they would like to add, please type them in the Q&A. And we have one here about our mental health in relation to dementia risk. Could you explain that a little bit more?
Well, one of the important things that we can do is rule out reversible causes of dementia, because when an individual is undergoing a mental health change, such as depression or anxiety, there can be a lot of overlap of the symptoms of dementia, and their cognition can be significantly changed where it's affecting their function. So by identifying mental health issues early, we can get the resources we need to treat them. That may be therapy, counseling, or it could be medications. What we may do is try to treat the mental health troubles and then reevaluate our physical and examination and cognitive function after we've treated to see if there's a change in cognition as a result of treating the mental health issue. So that's where we start. We want to rule out reversible causes. But as we said, depression is a risk factor for developing dementia. So it's good that we identify it to see if there's increased risk of developing dementia.
Wonderful, thank you. Can you explain a little bit more about how early someone can develop dementia? We talk about early onset, but maybe what does that actually look like?
Yes. So in Alzheimer's disease, we call someone who has developed Alzheimer's disease before the age of 65 early onset Alzheimer's disease. In these individuals, they can start to develop symptoms anywhere between perhaps 30 years to 65. Another subset of individuals who develop dementia early are those with Down syndrome. As I was explaining, in Down syndrome, you have 3 copies of the 21st chromosome. And on that 21st chromosome is a gene that we associate with early onset Alzheimer's. It's called the APP gene. When we have potential for 3 of those genes, we're producing more amyloid. So individuals with Down syndrome develop symptoms of Alzheimer's disease very early. The most individuals by their 50s with with Down syndrome will develop symptoms of dementia. So in those individuals, we see symptoms very, very early.
You. We talked a little bit about treatable conditions for dementia. So can you explain a little bit more about how something such as a urinary tract infection can bring on dementia symptoms?
Yes. So, in a urinary tract infection, oftentimes, particularly if you have a vulnerable brain, a brain that may be on its way to developing dementia, having that urinary tract infection can cause delirium. And delirium is sometimes hard to differentiate between dementia, but it's acute onset and it goes, you see really big fluctuations in someone's alertness in their cognition. And it's often caused by things like an infection. So we want to identify that cause right away and treat it because delirium can be lethal. Having a history of delirium does increase your risk of having dementia. So if you already have a vulnerable brain and then have delirium, you can develop dementia earlier.
Thank you. And this will be our last question for the evening. So if anyone has any follow-up questions, you are very welcome to reach out to us at the Alzheimer's Society of Saskatchewan by our helpline number, of course, by one of the emails provided. But as the final one, I think this is a nice one. Can you clarify just the difference between old age and a form of dementia, especially when someone is 90 plus?
Yes, absolutely. So this is an important message I want to get to communicate. Um, as we age, we may have very small changes in memory. It might be a little bit more difficult to remember names, but after some time, that comes back to us. There is a bit of change in processing speed, but not significant enough that it changes how you do your day-to-day tasks. It isn't changing how you are able to cook a meal or how you're able to go shopping. Uh, so the difference between being a 90-year-old that might answer you more slowly when you ask a question and someone with dementia is that the individual with dementia will have a harder time being independent in their function. I know lots of 90-year-olds that are very, very quick-witted. So this isn't a part of normal aging. Dementia isn't normal aging, it's a change in function.
Well, thank you, Dr. Gill. I really enjoyed your presentation tonight, and it was great to hear all the knowledge that you had to offer us and the community tonight. So I hope that everyone here really enjoyed it. And again, we welcome people to ask follow-up questions by calling our dementia helpline. And thank you all for joining us tonight and making this a great evening. So